talk a few points about delirium. I hope you have seen patients in your workplace, in your ICUs or hospitals, patients who are a bit confused. The confusion can be due to multiple reasons. Have you seen some patients like that? Having a confusion, irrelevant speech, altered sleep-wake cycle. Do you know what is the meaning of the word delirium? Actually, it is derived from a Latin word, which means to go off the track. That means to go from the normal, to deviate from the normal. Before going into all the aspects of delirium, I need each and every one of you to need to understand what is the importance of delirium, how prevalent delirium is in a hospital setting. Actually, in about 30% of the hospital patient can develop delirium, and in about 85% of patients in nearing the end of life develop delirium. What is the prevalence of delirium in an ICU? Can anyone respond in the chat box? Any idea about the prevalence of delirium in an ICU setting? I can't see any response. Yeah. In a study conducted of around 614 patients in an ICU patients, it was found that around 20 to 60% of the patients in an ICU develop delirium. See the number 60%, 60. Is that a small number? Obviously not. In short, 6%, 6 patients out of 10 develop delirium in an ICU. So, as nurses, as healthcare providers, we need to understand, we need to pick up delirium in the first stage itself. Coming to the definition, it is defined as a global cerebral dysfunction. Cerebral, something related to the brain, characterized by certain disturbances. Disturbance in alertness, awareness, attention, thinking, perception, memory, psychomotor, behavior, mood, and even the sleep-wake cycle. So in all, it affects almost all aspects. What about the onset of delirium? Actually, it is acute in onset. The symptoms develop from ranging from hours to days. Most of the delirium cases are reversible. There's an exception. Some delirium seen in the end of life period may not be reversible at times. Coming to the clinical features, there are a set of prodromal symptoms. What are prodromal symptoms? A mild version of the symptoms that is seen in the beginning of a disease. Like, have you heard about migraine? People having chronic migraine, they get that aura feeling. They get a sense of a disturbance, a sense of nausea before they develop headache. Like that, there are a set of symptoms called prodromal symptoms for delirium, such as restlessness, irritability, sleep disturbance. When you see a patient having when a patient is restless, when a patient is irritable, having sleep disturbance, we need to keep an eye on that patient. We need to check for delirium. We need to inquire more whether are there any other circumstances or situation that the patient is promoting delirium. Delirium has a fluctuating course. There can be in a day, during the course of day, there are times when the symptoms aggravate, and there are times when the patient can be normal. Attention deficit. This is a hallmark feature of delirium. The patient may have reduced attention span. They shift attention to new stimuli. The patient may have disorganized thinking. They may have irrelevant speech or incoherent speech. There can be increased or decreased psychomotor activity, altered arousal. The patients may try to escape from the ICU or from the hospital bed, remove medical devices. Have you seen patients attempting to remove the Rice tube or Foley's in your hospital setting? Obviously, many of you might have encountered such situations. They may also have affective symptoms such as emotional instability, sadness, anger, fear. They can even be happy or euphoric without any particular reasons. They may even become agitated. They may produce some aggressive noises. There can be altered perceptions also, like hallucinations. In hallucinations, what is hallucination? Can someone respond in the chat box? What is hallucination?
Please respond.
Yeah, a false perception. Somewhat right. So there are mainly two to three types of hallucination, like visual hallucination, auditory hallucinations, and visual hallucinations are more common in delirium. Before we go any further, I have listed some of the clinical features. Some of these clinical features may also be present in other diseases or conditions like dementia, psychosis, everything. So we need a diagnostic criteria to differentiate delirium from other conditions. So coming to the diagnostic criteria, there will be a disturbance in attention. The patient will have a reduced ability to direct, focus, sustain, and shift attention. The symptoms develop acute or subacutely. That is, it develops over a short period, hours to days. Symptoms may fluctuate also during the course of the day. We may see that the symptoms often worsen at the end of the day, during night time. This is called a sundowning phenomena. What is the reason for sundowning phenomena? Why are there any idea, any guesses why the symptoms worsen during the night time? Any response? I guess I'll have to explain. This is actually a boring batch. Without active participation, it's like listening to the radio. Okay. During the night time, when all the external stimulus, the surrounding sounds, the lights will be dim. The patient may experience that he'll be in some other world. So at that time, this can precipitate delirium, symptoms of delirium. The patient will become more anxious when it is in the dark. He may become what? Uh, he may have fear issues, anxiety, everything. Next, coming to the next diagnostic criteria, there will be change in cognition, memory deficit, disorientation, language disturbance, perceptual disturbance condition, which is not better accounted for by a pre-existing, established, or evolving dementia. And there is evidence from history or physical examination that the disturbance is caused by a direct physiological consequence of a general medical condition, an intoxicating substance, or medication use. Coming to the types of delirium, can mainly of two types: hyperactive, hypoactive, and there's a third one called mixed variety. What is hyperactive delirium? The patient will be restless, agitated, he'll be hyper vigilant, he may have hallucination, and delusions. This type of delirium is more associated with a drug intoxication, alcohol, or certain drug withdrawal. Whereas in hypoactive delirium, there will be psychomotor retardation, lethargy, reduced awareness of surroundings. Hallucinations and delusions are less common. This is more associated with hypoxic states like MI, stroke, or pulmonary embolus, metabolic disturbances, encephalopathy, and patients developing hypoactive delirium has a higher risk of death. Can you see this image? In hyperactive delirium, as I said earlier, the patient will be more agitated, whereas in hypoactive delirium, the patient will be more withdrawn. They will be lethargic. And in mixed type of delirium, patient can have both the type of symptoms. Coming to the causes for delirium, we have made a mnemonic. It's very easy to understand. Here, D stands for drugs. Can someone tell me what are the common drugs that cause delirium? Can someone respond in the chat box? Anyone working in a palliative care setting? Okay. Drugs such as opioids, antipsychotics, certain antibiotics like fluoroquinolones, many drugs are there that can cause delirium. So while using certain drugs, we need to keep an eye on the patient whether he is developing any symptoms, any adverse symptoms. Next, eyes and ears. This is a basic sensation of a human being to perceive, to have vision, to hear the sound. When a patient in an ICU, who is an elderly patient in an ICU or a hospital, who is not having his spectacles or a hearing aid, think of his condition. Will he be able to see the clock or hear what is happening around? Such patients can develop delirium. As I said earlier, low oxygen states or insults like MI, stroke, or pulmonary embolus, infections, retention of urine and stool. This is a very important point that we all miss in our practice. So when a patient presents you with symptoms of delirium, we need to ask whether when did you last pass urine? When did you satisfactorily last have a bowel evacuation? A time after seizure, that is a post-ictal state, uncontrolled pain. Will uncontrolled pain cause delirium? Obviously, yes. Some patients may complain of severe pain, whatever may be the cause. They may complain of severe pain. Okay, I'll give an example. A patient who's having a carcinoma of pancreas, complaining of severe pain for the last 2 weeks. He may be on some analgesics. He complained of pain for the last 2 weeks, and one fine day, he seemed a bit lethargic. He's not complaining of pain. There is no much response from the patient. So at that time, it should come in your mind that this can be a hypoactive delirium. So we need to give equal importance as we treat delirium to control the pain also. What are the metabolic causes for delirium? Any idea? Any guesses?
Dehydration.
Okay. Anything else? What about electrolyte imbalance? Certain electrolyte imbalances like increased or decreased level of sodium, potassium, magnesium, calcium, everything can cause delirium. And certain injuries to the brain like subdural hematomas. How will this delirium impact the patient or the caregiver? A patient having delirium, there will be functional decline. He will not be able to carry out his day-to-day activities. He may find it difficult to even go to the washroom. There can be increased number of falls. When an elderly person have multiple episodes of falls, they can develop fractures. When a patient develops fractures, what will be advising? To immobilize, to keep the patient to take enough rest. This will again decline the general condition. This is actually like a vicious cycle. The patient may develop incontinence. There will be decreased hydration and nutrition. And emotional burden is also a common thing. What is the pathophysiology, or why does this why is this delirium occurring? What is the science behind delirium? Even no one knows. It's actually poorly understood. It is believed that some of the neurotransmitters, when there is a difference in the levels of the neurotransmitters, it can cause delirium, such as due to the deficiency of acetylcholine and due to excess dopamine. And one key thing that we should keep in mind that not all individuals exposed to the same insult will develop signs of delirium. As I give an example of a case in which a patient who was having chronic pain developed delirium, it doesn't mean that all patients having pain will develop delirium. Okay? Are you all following? Should I slow down, or should I explain more, or should I go back? Can I get some response in the chat box? Should I repeat anything that I said earlier? Okay. Okay, then we'll go ahead. Delirium threshold is lowered in extremes of age, which means an elderly person having the above mentioned causes like pain, urinary retention, are prone to develop delirium more than a young person, or persons with dementia, persons with hearing or visual impairment. They can develop delirium faster. Persons who is a chronic alcoholic, people having depression, people with reduced physical activity, or with previous history of delirium, they can develop delirium faster. Coming to the triggering factors for delirium. Change in environment. How does change in an environment cause delirium? Think of our own grandfather or grandmother. When they are home, they will be used to their particular room. They will know where the bed is, where the table, where they usually keep the cup to drink water, where the bathroom is. They know how many steps, in what direction should they take to reach bathroom. So they will be familiar with their home or their comfort zone. So when you suddenly admit a person in an ICU or in a hospital, there's a sudden change in the environment. He will not find the table where he usually keep the cup for drinking water. He doesn't know where the washroom is. So this can cause anxiety. This can in turn cause delirium. An unfamiliar excessive stimuli, a too hot or too cold condition, even the crumbs in bed, the wrinkles in bed can cause delirium. Wet sheets. It is very important as nurses, as healthcare providers, to see how the we need to see the how the patient is having urination. Is he bedwetting? If bedwetting, are we providing any diapers? Are we changing the diapers in the correct at proper time, or are we changing the bed sheets stained with urine water at regular intervals? Think of a situation. Just put ourselves in a wet bed. Will we be comfortable in such a situation? Obviously not. A general deterioration or a worsening of the disease condition can also trigger delirium. As I said earlier, uncontrolled symptoms such as pain, fecal impaction, urinary retention, infection, dehydration, hypoxia, anxiety, depression, everything, if left uncontrolled, if not controlled at the correct time, can trigger delirium. Can brain tumors cause delirium? Primary or secondary brain tumors can cause delirium. When there's a tumor in the brain, the intracranial pressure, the pressure within the skull, within the brain, increases. This can cause altered signal transmission and can cause delirium. Certain paraneoplastic syndromes. What are paraneoplastic syndromes? Syndrome means a group of symptoms. Paraneoplastic means associated with a cancer or tumor. There are a lot of paraneoplastic syndromes. Just keep in mind that paraneoplastic syndromes also cause delirium. Biochemical disturbances like hypercalcemia, hyponatremia. As I said earlier, certain drugs such as opioids, benzodiazepines, antimuscarinics, certain chemotherapeutic agents, everything can cause delirium. Withdrawal states from alcohol, nicotine. Have you seen an alcohol addict when he's not getting alcohol? What will be his symptoms? There will be tremors, he'll be confused, he'll be angry. The same can occur with nicotine and other psychotropic substances. When there is an organ impairment, can be hepatic, renal, or respiratory, it can also cause delirium. Sleep deprivation. I have seen, even I have did it myself when I was an intern during my MBBS time. When I was posted in ICU in night time, I'll have to monitor all the patients in my ICU. At that time, even I used to chit chat with the people around. Sometimes nurses, sometimes the attender there. I used to play with my mobile. Will this disturb the patient? Is this the right attitude? I have done that myself. Is this the right attitude? When you make noises during the night time, think of the patients who are sleeping in the next bed. They may find it very difficult to sleep. This sleep deprivation can also cause delirium. It can occur. Delirium can also occur due to after a surgery, after a trauma or stress. There are certain assessment tools to assess the delirium. Just for your understanding, just go through the names. Different institutions uses different assessment methods. Coming to the next topic, there are certain conditions that resembles delirium, like dementia, depression, psychosis. You can see which among these four has how is the onset. In delirium and psychosis, the symptoms can develop acutely. See? What about altered level of consciousness? Altered level of consciousness is seen mostly in delirium only, whereas in dementia, depression, and even psychosis, the level of consciousness is intact. Just go through all the points, okay? And just for some extra understanding, you can read it later. How is delirium different from dementia and depression and psychosis? Are you all with me till here, till now?
Somebody please respond.
Yes.
Otherwise,
Yes.
Huh? Should I repeat something? Did I miss something?
No.
Can we go to the management part?
Yes.
Always, coming to the management of delirium, always correct the correctable. Not only in delirium or wherever possible, always correct the root cause of delirium. See, what is causing delirium in this patient, in my patient? What can be the reason for delirium? Is it because of certain drugs like opioids, like morphine? If so, reduce the dose. Try to get any alternative drug if possible. Is it due to fecal impaction, given enema? Is it due to urinary retention? Is it due to infection? Is it due to some trauma? So always correct the correctable causes, correct the electrolyte imbalances, if any. Then we'll go to the non-pharmacological methods for management of delirium. This is actually very important that we all neglect. When we see a medical condition or condition, we always prefer the medical management or pharmacological management. We usually neglect the non-pharmacological side. But in delirium, the non-pharmacological management plays a key role. It helps the patients a lot. Some of the relevant points are we need to optimize the sleep-wake pattern. We need to orient the patient. The patient may not be oriented to time, place, or person. We need to repeatedly reorient the person. We need to have effective communication. We need to encourage mobility as far as possible. Monitor hydration and nutrition. Thus, we can prevent electrolyte imbalances to an extent. We need to monitor bowel and bladder functions. And finally, providing support and education to both patient and as well as the caregiver. How can we optimize sleep-wake patterns? During the daytime, we can increase the exposure of sunlight or lights in the room to a patient. Open the windows and make the patient see that it's actually a daytime. We can tell him that at daytime it is not good to sleep. And we can lower the lights and noise during the night time. We can initiate or start certain sleep protocols, such as some gentle massages. At least some of you will have a habit of drinking warm milk before you go to bed. So such an initiation of certain sleep protocols can help the patient. How can we orient the patient? Again, we can repeatedly tell the patient that what time it is, what day it is, which month of the year this is. Explain where they are, who you are, what you are doing, why you are admitted, why you are in this place. If patient have a hearing issue, we can keep a whiteboard, or in this era with laptops, tablets, mobiles, we can even write something and show him. Keep a visible clock. We keep a clock near to the patient so that the patient himself can see the time. In my hospital setting, I think we have around 4 to 5 clocks near the patient bed. So almost all the patients admitted here can see time. This actually helps a lot. Have you seen this guy? What is this guy doing in the movie? Can I see the chat box? What is Amir Khan repeatedly doing in that movie? After a trauma, he forgot everything. he actually did whatever possible to what? To recollect. He did everything. He made tattoos. So I'm not telling that we need to give tattoos to the patients, but thus we can repeatedly telling all these things, we can reorient. Have good communication and good sensory stimulation. Give eyeglasses. Give hearing aids and dentures. A person who was using dentures for the past 20 to 30 years, when they get admitted to the ICU, if you remove the dentures all of a sudden, they may feel that a part of her body is not there. It can cause certain disturbances. Encourage mobility. As far as possible, never restrain a person. When we restrain a person, will his symptoms reduce? Is he able to comprehend that I need to calm down because of my restraint, because of the handcuffs? No. He will try more. He will have more anger issues. His agitation, anger, everything will increase. So, as far as possible, try not using restraints. Mobilize as much as possible. Make him sit out of bed for meals if possible. And minimize use of catheters. An elderly person or a person with a chronic illness, they may even get up from bed to go to the washroom. What will happen if you catheterize that person? From the next day onwards, he stops getting up from the bed, even to go to the bathroom, because there is no need. He may become more dependent. So minimize use of catheters as far as possible. Monitor bowel and bladder function. Assess for urinary retention, constipation. If the patient is constipated, give laxatives. Fecal impaction. Check for fecal impactions. Provide support and education. Involve family in such discussions. Tell family members or caregivers that the symptoms that you see now are not due to some madness or something. This has developed. Tell him that this such and such have caused delirium, this symptoms, and this is reversible. And we need to make certain changes in his environment, in his lifestyle, in his way of treating, so that he can come out of the symptoms. Ask them to reassure the patient in a calm voice. At last, what are the pharmacological managements? Just give me 1 minute.
Please wait, there is an issue with our internet connectivity. Please wait for a minute.
I'm sorry for the inconvenience caused. There was a technical problem from our side. I'm sorry. So let's continue. Coming to the pharmacological management of delirium. When is pharmacological management indicated in a patient or case? Only when the non-pharmacological methods have failed or the patient is distressed. The patient is at a risk to themselves or others. And if the patients are very much agitated. Only in these four conditions, there's actually only in these four situations, pharmacological management is indicated. It's actually basically to target two symptoms: perceptual disturbance and agitation. We can use antipsychotics like haloperidol, which is a drug of choice for treating delirium. The common dosage is 1 to 2 milligram every fourth hourly. It can be given orally, subcutaneously, or intravenously. In an elderly person, we need to slightly reduce the dosage to 0.25 to 0.5 milligram. In my hospital setting, in our hospital setting, we have tablets of 1.5 mg. So we try to give oral medicines if possible. If not, we go for subcutaneous or intravenous routes. What will happen if we increase the dose of haloperidol? I need to see how many of you have listened to my previous class. What are the drugs causing delirium? Have I mentioned antipsychotics? So antipsychotics can also cause delirium in higher doses. So the dosage is important. So the maximum dose of haloperidol should be between 15 to 20 milligrams in 24 hours. We also need to keep an eye for extrapyramidal symptoms. Next, benzodiazepines like midazolam or lorazepam. This is indicated only for hyperactive delirium. Midazolam can be given as a 1 to 2 milligram in every 2 hourly in a subcutaneous or through intravenous routes. And the maximum dose should be less than 30 milligram in 24 hours. Or we can also give lorazepam. When we deal with an end of life, a patient or a patient nearing the end of his life, we need to be cautious while giving antipsychotic like haloperidol along with a benzodiazepine like midazolam. Why? Because the patient can go into deep sleep till death. So, as far as possible, if the patient is not in hyperactive delirium or if it is not indicated, try avoiding benzodiazepines. You can actually repeat the dose of haloperidol in 20 minutes. Give 1.5 milligrams subcutaneously. Wait if the symptoms are subsiding. If not, wait for 20 minutes, 20, 30 minutes. Repeat, give another dose. So, as far as possible, we need to try to avoid benzodiazepines. Any doubts? As you can see, haloperidol it causes sedation, but comparing to the other drugs, the sedation effect is very less. This for your own understanding, you can go through this later. We can conclude the topic. So, I need one of you in the chat box. Can you tell me what is delirium? What are the features of delirium? Anyone? You're making me sad. I don't want to teach you anymore. Okay.
Confusion.
Okay. Confusion. Okay. Good. Okay. So coming to the last part, always correct the correctable. Correct electrolyte imbalance is agitated. Yeah. Yes. Yes. Hallucinations may be associated with hallucinations. Good. I'm not having my spectacles right now, so I find it hard to read out the names. So pardon me for that. You have done, yeah. What all you have said is correct. So coming to the management, always correct the correctable causes like electrolyte imbalances or infections or urinary retention or fecal impaction. So always correct what is correctable in that case. Go for non-pharmacological management as far as possible before considering the drugs. A multidisciplinary approach may be needed. Always communicate and take the caregivers along. Educate them that these symptoms are not madness. Tell them that what we can do at home or what we can do right now to improve the symptoms. Identify hypoactive delirium and treat. Identification of hypoactive delirium is very important. In hypoactive delirium, since the patient is lethargic and weak, we may often feel that the patient is lying down like that because of his illness, due to the worsening of the underlying condition. So we need to keep an eye to identify hypoactive delirium and treat the case promptly. Any doubts? Please use the chat box. Any doubts? Would you like to share any experience that you had in your hospital setting or in a home care setting that when you encountered a patient who is confused or had delirium? Anyone wants to share an experience? Okay, then we'll conclude. Thank you all.
Thank you, Dr. Tony, for the wonderful presentation. Anybody have any doubts? I hope this presentation is clear to everyone, but we nurses, I would say most of the time we are spending with the patient. So we are the apt persons to diagnose the patient who is having delirium. So this is very, very important, especially the nurses. This is one of the important symptom in palliative care. So we have to understand that what is delirium and what are the cause of delirium, how can we treat delirium. So these all things we learned from today's class. If you have any doubts, please ask now.
I would like to share an experience regarding my uncle who had delirium before I went to the UK.
Yes,
I think it was not, I don't know, for some reason I was not very much aware that delirium can be a cause of sepsis. So what happened was, when I when I look back, unfortunately we did lose our uncle, but when I look back, I remember he telling me that he is seeing things and somehow he is forgetting. He knows that he's forgetting. It is not on purpose. And he was asking like, he had come from the US. So when he was admitted in the hospital in Nepal, he was asking me, is this particular auntie coming? And I said, no, she's in the US. And he was like, oh, yeah, I'm in Nepal, isn't it? And then back and forth, he was going like that. Unfortunately, he was not treated on time and we did lose him. So it is that serious, delirium, to identify delirium, especially for nurses, because we're always with the patient. And if we see something like that, a sudden change in a patient's behavior, their perception, and their, understand, especially if family members tell us that this is not how this person is. Or maybe a daughter will say, this is not my father, he's behaving differently. I think we should alert our doctors and let them know that there's something serious going on.
Okay, Dachin, thank you for sharing this story. Sorry to hear that news. Anyway, as Dachin said, we all nurses have to understand that if there is any confusional state there, we have to understand that whether there is any treatable cause. So we have to identify whenever you have seen a delirium, the confusional state patients, you have to identify the cause of delirium, whether there is any correctable cause is there or not. For example, is a constipation, chronic constipation and retention of urine. As said, electrolyte imbalance, hyponatremia, hypoglycemia. So these kind of patients can develop delirium. So we have to, whenever you have see a patient with delirium, just ask the history first, and then you have to, if there is any correctable things there, you have to correct it. So then we can, this is most of the time the delirium is reversible, but if there is end of life care delirium there, that is not reversible, but most of the delirium we can reverse. Any other questions or experience sharing? Anybody have any other experience also, you can share. Unfortunately, we don't have a case presentation today, so we have time to discuss. If you want to share anything, please. So, if you don't have any questions, we can wind up. But this is very, very important because today you have learned many things, especially the causes. There are precipitating factors also. Whenever you have, usually we admitted patients in intensive care unit. Inside the ICU, there is no unfamiliar faces. We are nurses. Our unfamiliar faces can cause delirium. They don't know who are you. These kind of things and don't orientation is not there, and monitor sounds. So these all things can be precipitate. So these all things you have to keep it in mind if there is any things happen. So, and we usually do is we restrain their lips, right? When nurses first is our duty. If there is any confusional stage there, they be used to restrain their lips. So instead of that, you have to think about these, whether there is any correctable things. So instead, restraints, you have to think that, and if there is any correctable cause there, you have to try to correct it so that we can avoid the restraints. So, so that is also one of the important points you have to keep it in mind. And some of the medications can cause delirium. So, for example, morphine. So, one of the toxic effect of morphine is delirium. So, that is also, if there is a delirium patient there, you have to check the medication history also. We can't change that medication because morphine is the good drug for pain relief for that patients. We can't stop that morphine, but we can give some medications for that if you identify that. But other than that, you have to check the other causes also. Morphine can cause constipation. One of the most common causes is constipation, right? So the side effect. The one of the most common side effect is or side effect of morphine is constipation. So the constipation can cause delirium. So you have to check these things also. So if there is any correctable cause there, always try to correct it. And as I mentioned earlier, most of the time the delirium we can reverse. If there is any terminal stage delirium there, we can't reverse. So we have to treat the person as respect, and also as Dr. Tony mentioned, you have to educate the caregivers about this is not mad. That is very, very important. They might be thinking like this is mad. So if their loved ones develop confusional state, they might be thinking like that. You have to give a psychological support, and you have to give a reassurance, and these kind of things from the nurses side you can do. Without doctor support, you can do. So you have to treat the patient as respect, because after that, if there is any reversible situation there, definitely after that they will recollect all those things. We have to respect that patients, even if the patient is having delirium also. Delirious stages also you have to respect courtesy. So these all things you have to keep it in mind. Okay. So if you don't have any questions, we can wind up. Thank you for your participation. Thank you, Dr. Tony, for taking a wonderful session for us. Thank you all.